So as a part of lateral recess decompression, we should always try to drill or remove some part of SAP from medial side, because SAP is something which is compressing our traversing route. So we need to remove that. And once you make space in your lateral recess, it's very easy to work and on the disc space and on the traversing route without retracting too much over the side. So good lateral recess decompression is must. So everyone have their different, I think, methods depending on their expertise and their comfort. While some people prefer to use drill for the bony work, while sir is using most of the bony work being done with the help of Garrison. And you can see the diseased phlegm was phlegm. And the upper part of phlegm is now visible under the superior lamina. And most important thing is to know that phlegm is not a box-shaped structure. The phlegm was to the cover over the exiting roots in the superior part and the traversing root in the inferior part, like a butterfly. So like a butterfly which is somewhat narrow in the center, and in the periphery it's more rounder wings. The phlegm is like that only. So that's what we can see clearly here. In the medial part, the phlegm upper edge has been delineated clearly, but on the lateral part, still we have to do some more work to clean out the phlegm. So that butterfly's upper wing, upper tip of the wing and the lower tip of the wing has to be taken care very well to do the complete removal. So in UBE we can call them as blind spot. So I think UBE is the one surgery where you can easily see these blind spots by taking your scope right there into the blind spot, and you can remove the phlegm from the blind spot. So if you don't do this decompression, in canal stenosis cases, sometimes your patient have recurrence and or they come back immediately in the post-op with the pain. So that has to be taken care for the young surgeons who are starting UV. That butterfly's wings has to be taken care completely. to to see the thicker to see the thicker side clearly. So one thing is important. You can see this work is being done under the spinous process to see the opposite side clearly. So you can call it under the roof, you can call it over the top, however you name it. Just one thing has to be taken care while we are doing this. The phlegm has to be kept intact so that it prevents injury to our fecal sac. So one thing I would like to say here, if we remove the phlegm without doing bony work, sometimes in center there is a denting in the fecal sac. So what happens when we cross that denting area again and again and try to go and work in the opposite lateral recess, we are prone to injure that denting. So that's why we try to keep a layer of phlegm intact over and then go and do the opposite work. Many of the time we need to drill in the blind space or the opposite side lateral recess. So if we don't have a protected bulb, then you can see now we can see the fecal sac very clearly. So good thing with the water medium system is the moment you open up phlegm, the water pressure itself keeps your dural sac, fecal sac away from your instrument. Unlike the microscope or other dry medium endoscopy systems like the Stendu or anything. I'm not saying they are not good, they are very good in the expert hands, but as a beginner we are always in a fear that once we remove the phlegm, we are always at the risk of injuring the dura because then the dura protrudes. But here in the water medium, the water itself keeps the neural tissue thecal sac away from us. So that's one benefit of water medium I can say. Worth using. Any comment on that, sir? Am I audible in the auditorium?
Yeah, absolutely correct. Actually, we are speechless.
So phlegm has been removed in the piecemeal manner here. Carefully inserting our calycin and carefully ruling out that there are any adhesions between the fecal sac and the phlegm. Lifting it gently, and while you lift it gently, you can even see underneath the phlegm and then carefully lifting it watching inside that there is no adhesion or no dural impinging into the calcium and then resecting it. So, can you see the dural bands?
Yes, yes, very much.
These are the reason when we are not cautious and we are trying to pulling off the phlegm from the dura blindly, they are responsible for causing dural injury unknowingly. So we have to take care of these bands before exercising the phlegm. Yeah. If at all they are there, we can excise them with any sharp object. Just now, sir has retracted the root at the shoulder and shown the disc. So, decompressing this part, third retractor works very good to reach those corners.
नवेद तुम्हारी तुम भी स्पीचलेस हो गए। बोलो नहीं, हम लोगों को नींद आ जाएगी।
Sorry, sorry, sir.
अरे हमने कहा बोलते रहो, नींद आ जाएगी, इतना अच्छा दिख रहा है।
Sir, you can just enjoy the show, sir.
No, but without audio, how can we enjoy the show?
Sir, so sir is removing the
Yes,
the
yes, thank you.
phlegm in piecemeal manner from the shoulder of the disc. He is going down. We have already seen a glimpse of the disc. So, academic fact, you can see. So it's very necessary to remove this phlegm in the lateral recess, or else it will be impinging again over the traversing root the moment we take out the water. So I'll again orient you.
Yes.
So where our ranger is, that 6 o'clock is toward left side,
Yes.
9 o'clock is cranial, 3 o'clock is caudal, and 12 o'clock is medial,
Right.
which is the cause of pain here, which is getting compressed and causing pain. Then we can take care of the exiting route afterwards.
Okay.
Yeah, if needed, yes.
Sure.
So very unlikely it is affecting the exiting
No,
route.
no, it is traversing, affecting the
Yes, sir.
traversing.
Yes, sir. So good thing is you can see no root retractor has been used here, and that's possible because the good lateral decompression has been done to make space. So you need not even retract the thicker side or the traversing route even a bit, and you can easily do your work lateral to that. So disc is coming out on your camera. Can you show the disc which is being coming out? So one thing I want to comment here, must say I'm not very experienced surgeon, but what I feel only the loose fragment, soft fragment which are coming easily, that's my practice, that I only take out those fragments. I do not chase to remove the entire disc or the disc which is healthy and difficult to pull out. So that's what I do. Whatever soft disc is coming easily, I remove that, and then I again try to close that defect of annulus by doing annuloplasty. Dr. Astosh?
Yes.
Sir,
Yes, sir. Yes, sir.
Do you also feel the same, or you like to chase the disc?
See, in my practice, I usually remove the disc completely.
Okay.
So I go more lateral. I do a wide anatomy, and then remove it as much as possible.
So do you
That's
feel
just not required.
need of putting cage when you do this much of
No,
disc?
no. It's usually not required.
Dr. Arvind doing, it is the purposes only.
Yes, sir.
So it is not that you are scraping the end plates clean,
Definitely.
right? So you should remove as much as possible. Great job.
So, finally the baby is out.
Yeah, very timely, so that we can go to the cruise also. And we can do the discussion of endo versus micro with all sorts of endo on the cruise. While we are taking snacks and food.
So,
कुछ बोल रहे थे अरविंद?
no, sir. Sir is saying he has just had lunch and I think it's too soon for the cruise and.
No. What the cruise means, by the time you start and go, cruise will start at say 5:30 to 6, and then you will see आरती and all. बिना आरती देखे थोड़े खाओगे. उसके बाद थोड़ा बहुत स्नैक्स खा लेना, बाकी तो होटल में आके फिर खाएंगे, क्या दिक्कत है?
Sir, doctor, I'm handing over the mic to Neeraj sir.
नीरज,
Sir,
वो एक बार रूट भी दिखा देगा पूरा, फिर उसके बाद हम लोग यहाँ बंद कर देंगे.
sir, I think the work here is almost done.
Done, yeah, 90,
We will be changing one more fragment if possible.
Yeah.
It's not
And
moved already.
just show the length of the route if people wants to see the force of the
Complete
route.
length of the route.
Yeah.
Yes, sir.
And then Neeraj.
Yes, we will start the panel discussion and then we can start moving to.
That's
towards
what
the
I'm
cruise.
saying. I think we should move towards cruise after say 5-10 minutes.
Yes, sir.
So it will be better that you might get some traffic and all. So
Yes,
we
sir.
reach there in time. We can have discussion on cruise also.
We can have panel discussion on cruise. That is the best thing we can have, sir.
Yeah. That is all.
So I think by 15 minutes,
Yeah,
you
yeah.
can start mobilizing the faculty.
Yeah.
All the cabs are there outside park only.
Right.
So you can start mobilizing. I'll be bringing Gaurav sir and Dr. Arvind with me.
Yeah, it's
So
okay.
you can start mobilizing by 4:45 so that we can reach the on time. So we will be having the dinner also on the cruise only, not only snacks.
Yeah, let it be some light dinner there.
Yes, sir. It's proper authentic Banarasi
Yeah,
dinner.
some chaat waat khayenge.
Yes, sir.
Great.
Yes, sir. So maybe you can start by 4:45.
Yeah, 4:45 will start.
Yes, sir. So finally, we are just doing the last bit part of the dish, sir, because it's a hydrated dish, not a very dehydrated dish that will come in one fragment. So that's why it's coming in
Gaurav has
pieces.
done nicely in time. That is, must give feedback.
So we knew Dr. Gaurav would do more time, sir. That's why he was given the toughest job of last week. Each bite is taking some part of this along with it. It has come in lot of small pieces here.
सर हर चीज अनोखी है वाराणसी बहुत ही सही है
बहुत ही टेस्टी है।
ये शेप भी कितना
हाँ, वही तो।
बहुत ही सही।
इसमें पीने का एक अलग ही
We are going into the dish. We are trying to update the purposes, analysis. The root looks very different. The initial part, if somebody remembers, it was very bunched down, highly vascular analysis popping out of the picture here. Now it has comparatively long size. But yes, as Dr. Dhawan is also trying, there is some part left there. It's a big fragment coming out. Definitely. Now we can see the big fragment coming out. So this happens when we do our leg, there is like dehydration of the disc, when it gets caught hold in another big fragment. Gets caught hold in the process, and now you can see it in the liver. It's a big fragment. It's a very, very big fragment. Yes. So this, I think, yes, now. So I think we have decompressed it very well. There was a fragment that was causing discomfort to the surrounding.
फिर वही डेट चलिए कोई नहीं अगर
Actually, till that fragment comes, the surgeon is not happy. We have to have a feel of a long segment coming out that makes us proud. Decompression has been done that way. This keeps on coming, keeps on coming. Keeps on coming.
हाँ जी हाँ जी
हेलो हेलो
For such kind of cases, I don't know what are the stopping points. But what I have learned from past 6 years from my guru, Dr. Adok Ojha, keep a weighing machine in OT. Measure 3 gram, 4 gram. If 3 gram disc has been removed, you have removed enough. Don't try too much. You will destroy a good surgery by trying too much.
That's what I told in my talk also.
Yes, exactly.
Energy and experience. So the combination of energy, experience, the long term, if you have to do neurosurgery, because neurosurgery is going to be difficult now. Any surgery, any surgical branch, this NMC new criteria. So better to make a team which should be, the vector should be in the same direction. And then you keep on working and you will keep on growing. And if you work individually, you might grow little bits sometimes, but you have health issues, you have other issues. So this thing is that one should be, at least the teamwork should be there.
Yes. I think the neurosurgery is the one field which requires typical teamwork.
We are lucky to have Neeraj and new Dr. Sunil has joined from BHU. So we have really, now we are 11, now 111, we are 111.
So as you said, sir, we are trying to denude the complete force of the clavicula. The last part of the ligamentum flavum that is attached to the SAP, going towards the superior border of the inferior level. So we are trying to just remove the ligamentum flavum from the superior border of the inferior level. So we will see where the nerve root enters the foramen.
बच्चे सब बहुत अच्छे से
There you can see, if you see the angulation, he is trying to manipulate in a reverse manner going downwards. So this all things will take your expertise. This is not an easy thing to do. You rotate your upper downwards along the course. I think when we are putting this, we are putting it along the course of the movement.
Neeraj,
Sir.
just ask Gaurav,
Ah,
he is not in the axilla, no?
no, sir.
You can see the roof because I have not seen the roof here.
That is the route, sir. That is the route.
ट्रैवर्सिंग
Yes, sir.
ट्रैवर्सिंग
Getting the नीचे.
दैट इज शोल्डर सर
उसके कैरियर के नीचे.
वो शोल्डर है कैरियर के नीचे
It's getting separated.
Okay, okay.
It's getting separated.
Yes, sir.
Okay.
Now it's okay, sir.
Yeah, now it's angle, yes.
Yes, sir. That's what he's trying to do actually. He'll show you the entry of the loop into the foramen. Then it will be more clear.
ये भी लेट ब्लूमिंग है लेट ब्लूमिंग है सर
बहुत लेट म्यूजिक
हाँ.
तो फिर वो पल्स के लिए थोड़ी हो गई एक हमने शराब निकल जाओ हाँ
So we can see how rounds are going inside the foramen, trying to do the foraminotomy. So just lateral to that, we can also feel the pedicle of the L5. And our traversing root, just this is our foramen, and sir is feeling the pedicle toward the lateral side of the traversing root. So this instrument is going between the pedicle and the traversing root, and it itself says that so much space has been created, adequate foraminotomy has been done. Yeah. So I think the baby was delivered, but the twins was inside. The twin has been taken out. These small fragments, sometimes if left behind, they can cause recurrence. Judicially, they have to be removed. Hello. So, please show the axilla with the endoscope.
If you are comfortable.
So, for getting into the axilla, we need to dissect somewhat.
Yeah,
somewhat more.
leave it. No issues, no issues.
So in this case,
Yeah, we can see. With a dissector, you can show just remove.
Sir, please show the root with the dissector
Yeah.
as.
The course of the root, that is all. Same.
So
Yeah, it's okay.
that's the traversing root.
Yeah. Yes, we can see. Now it's
Can-
going down inside the canal.
Yeah.
Yeah, done. Thank you. And 3 cheers.
Thank you very much, sir. I think just round of applause for that. Thanks a lot. So,
ये बैग किसका? अरे पवन निकुंज का है ना? हाँ, तो निकुंज चला गया क्या? छोड़ गया क्या बैग? जरा पकड़ लो यार उसको, मेरी गाड़ी में इम्पोर्टेंट होगा उसका। वो किसका है, वो कैसा है उसका? निकुंज का ही है। क्या नाम है? गौरव बंसल का है। गौरव बंसल का है।
जो वाला ना ब्लैक वाला।
ले लो भैया, इसको दो ना। ये सब उसी का है, मेरी गाड़ी है ना पास?
मेरे पास
क्या करें सर, बंद तो करें, टाइम हो चुका है।
थैंक यू
सर सब जा रहे हैं। हाँ कब
ओके ओके।
रात में
कहाँ पे हो अभी? मैं अभी हैदराबाद में हूँ। आई वाज विद नीरज।
नहीं हो गया।
नीरज और मैं वी आर
देख
बैच
रहे हैं,
में।
लेकिन हो गया। हाँ सब जा रहे हैं, हो गया खत्म। अब क्या देख रहा हूँ, देख रहा हूँ।
अभी चलेगा उनको दे देते हैं आपको।
सर कुछ आयु ले बेटा कहीं जहाँ चलना चलो चलो बात आपका चला था, बंद कर दे।